Thank you, Vice Chair Doniate. For the record, Patrick Ashton, Committee Policy Analyst with the Legislative Council Bureau. Chair Peters requested an overview of the work of the committee to conduct an interim study concerning the costs of prescription drugs for the 2019-2020 interim. I was the Committee Policy Analyst of this interim study. And let me begin by briefly summarizing Senate Bill 276. The Legislative Commission established a committee to conduct an interim study concerning the costs of prescription drugs as directed by Senate Bill 276, which was passed during the 2019 legislative session. The committee was comprised of 6 legislators, 3 from the Senate and 3 from the Assembly. You can see the membership on this slide. Pursuant to SB 276, the committee was tasked to consult with and solicit input from persons and organizations with expertise in matters relevant to the cost of prescription drugs. Specifically, the committee studied and examined the overall costs of prescription drugs in Nevada, including a comparison of those costs with other states, the impact of rebates, price reductions, and other remuneration from manufacturers on the overall costs of prescription drugs in Nevada, and opportunities and options for lowering the cost of prescription drugs to make those drugs more affordable for Nevada residents. The committee held 4 meetings during the past interim. At the committee's final meeting and work session, it approved a total of 5 bill draft requests. I will provide you with a brief overview of each one of them. First, Senate Bill 396 authorizes public agencies to establish intra- and interstate purchasing coalitions. Such coalitions consolidate the purchasing power of agencies within a state or different states to obtain prescription drugs in bulk in order to negotiate lower prices from wholesalers or directly from drug manufacturers. This bill passed during last session, and you will receive an implementation update on SB 396 later from Dr. Beth Slemowitz under Agenda Item 11. The second BDR from the interim study became Senate Bill 201, but it did not become law last session. It passed Senate Health and Human Services and was amended to allow licensing fees of pharmaceutical sales representatives to cover the cost of licensure and regulation and for the purposes of the Prescription Drug Transparency Program with DHHS. The bill received no further action after being referred to the Senate Finance Committee. The third bill, Senate Bill 380, passed last session after being significantly amended. SB 380 built on legislation concerning transparency of asthma and diabetes prescription drugs from the 2017 and 2019 legislative session. It removed the existing requirement that DHHS compiles a list of essential asthma drugs. Instead, it requires the department to compile a list of prescription drugs with a wholesale acquisition cost that exceeds $40 for a course of therapy that have increased in price by more than 10% in the last year or 20% in the last 2 years. There are some other reporting requirements, but you will hear more details during a DHHS presentation under Agenda Item number 10 today. Of note, the introduced version of SB 380 required manufacturers, wholesalers, and pharmacy benefit managers to register with the department. The registration fee would have allowed to be calculated in a way to produce the revenue necessary to cover the cost of the activities of the Prescription Drug Transparency Program administered by DHHS. These sections were amended out of the bill. SB 392 was referred to Senate Health and Human Services, but never had a hearing last session. The bill would have required the licensure of pharmacy benefit managers, or PBMs. Some other highlights of the bill were to prohibit PBMs from using spread pricing, and spread pricing occurs when a health plan provider contracts with PBMs to manage their prescription drug benefits, and PBMs keep a portion of the amount paid to them by the health plan for prescription drugs. The bill also would have required a PBM to allow a client, such as a health insurance provider contracting with a PBM, a full audit rights, including but not limited to pharmacy claims, rebates, and similar information needed to assure compliance. And the bill would have established a fiduciary responsibility for a PBM to a third-party payer. The benefit of the payer is the primary and sole interest of the fiduciary, and any conflict with that role must be disclosed and avoided. SB 378 did not receive a hearing either after being referred to Senate Health and Human Services. The bill would have required prescription drug coverage from the first day of coverage with no deductibles, fixed prescription co-payments, which allow patients to pay a flat dollar amount per prescription and is not percentage-based, and limited co-payments of not more than 1/12 of the patient's annual out-of-pocket spending maximum. This concludes my presentation, and I'm available for questions. Just a reminder, we also have subsequent presentations on 2 of the bills I just summarized. Representatives from DHHS will be available for more detailed questions about the implementation process. Thank you.
Thank you so much, Mr. Ashton. Does anyone have any questions for him at this time? See none here and none in Las Vegas. I think we'll go ahead and proceed to the next presentation. So let's move on to agenda item 10, which is the implementation update on Nevada legislation related to pharmaceutical drug pricing transparency pursuant to Senate Bill 380. Our presenters today are Ms. Linda Fox, who is the Pharmacist Drug Transparency Program Manager at DHHS, and we have Jessica Gerhau, who is a Management Analyst in DHHS. We also have, just for transparency's sake for the members, after they're done presenting, we also have Dr. Kapuro, who presented earlier, Dr. Beth Slamowitz, and David Olson, who could answer any questions that may arise. So Ms. Linda and Jessica, please proceed when you guys are both ready.
Okay, thank you. Good morning, good afternoon. And Jessica is going to provide slides. I am Linda Fox. I'm the Program Manager for the Nevada Drug Transparency Program. I appreciate the opportunity to speak with you today. What I provided is an overview of the Transparency Program, what it does, the highlights from the program's report this year, as well as a review of the past 5 years of the program. So a brief timeline, you can advance, Jeff. 2017, SB 539 was introduced and created our transparency program. This required DHHS to provide a list of essential diabetes drugs, as well as a list of those drugs that experienced a substantial price increase in the past 2 years. Manufacturers of these drugs were required to submit information regarding drug costs, and for drugs that experienced a significant increase, the reasons for those increases. PBMs, pharmacy benefit managers, also had to report certain information. Manufacturers had to identify pharmaceutical sales reps, and sales reps had to submit an annual report regarding their activity. So that was 2017. In 19, asthma medications were added to the essential drug lists, but they were repealed the following legislative session. So what happened in 21, the asthma drugs were removed. However, they were replaced by a different group of drugs, which was essentially all drugs, as long as it met a certain price increase criteria. So it was drugs over $40 that increased 10% in 1 year or 20% in 2 years. But it was a drug. It could be any drug. It didn't have to be an asthma drug or any other particular kind of drug. And diabetes remained as well. Wholesalers were added to the entities required to report. And it was just mentioned, SB 201 was introduced that year that would have required licensing of drug representatives, but that bill failed. The fees for licensing would have helped to support the operation of the drug transparency program. So presently, This program is staffed by 2 contract employees, a pharmacist that manages the program, and a management analyst. Penalty fines for non-reporting are used to fund the program, including staff and resources. The penalties paid over time have decreased because these entities have increased adherence, and in general, they report what they're required to report. So the first year of the program, there were no fines. It was a free year until it allowed people to learn how to report to the program. In 2019, there were about $1 million in fines. In 20, it was about $250,000. And interesting, it was not any of the same companies. So 19 and 20, it was completely different companies that were fined. In 2021, there were no fines at all collected. This year, at this point, there is 1 fine that's being administered. It is being appealed. So before I kind of go over what happened this year with reporting, I wanted to briefly explain the drug lists that we make. So there's 4 lists, 4 lists that are published in February. The first one is really for consumers. It's a simplified brand generic list. The second list is a list of essential drugs that are used for diabetes. It has its own set of reporting. Lists 3 and 4 are drugs that had significant price increases. So list 3 is diabetes drugs with a significant price increase. List 4 is all the other drugs I mentioned that are over $40 that have a price increase. 3 and 4 are different lists because they have different criteria. And I think that's all I'll say about this. So pharmaceutical sales reps are required to register with the program and report any activity over $10 per recipient or $100 in aggregate. You can see there the results of this year. So 266,000 reports submitted, over 5,000 active reps in this state, more than 1,700 had reportable activity. $3.4 million total reported in compensation is much more than last year. Last year was a little over 2 million. I think probably some of that is because of COVID, but it does go up each year fairly significantly. Pharmacy benefit managers are required to report certain information regarding drugs on Nevada lists 2 and 4. 13 had reportable data. There was some inconsistency in the reporting that made it difficult for me to aggregate. And some of it, this is the first year we required PBMs to drill down to an NDC number, and some of them had difficulty with that. So the ones that I could collect information from, I did. In addition, it's difficult for us to tell which PBMs need to report to us. With manufacturers, it's very straightforward. I have a database I use, who made the drug, did the price increase. I don't have anything like that for PBMs because we don't know which drugs they handled. That is also the case with wholesalers. We don't know who is supposed to be reporting. So wholesalers were added this year. They're required to report certain information. We had 3 report this year. Only 1 had usable data. And as I mentioned, there's no clear way for me to know who was supposed to report to us. Okay, so I have the highlights here of the report this year. Over 1,000 unique NDCs for essential diabetic drugs. So those are not drugs that necessarily had an increase. Those are just drugs that are used for diabetes. Of those drugs, 151 did have a significant price increase. On list 4, the over 40 list, there were about 180 NDCs. I think when SB 380 was becoming law, there was no good way to tell how many drugs would be drawn in by that net, the over 40 and the 10-20%. But it ended up with 180 NDCs, which in my opinion is not a very high number. More than 25% of the drugs on the over 40 list were opioids. The average cost of a Medicaid claim in Nevada was $109. For an essential diabetic drug, that was $263. A diabetic drug that appeared on the significant price increase list was $753, and a drug on the over 40 list average was $948. The highest total cost Medicaid drug was indicated for treatment of HIV. Manufacturers were required to specify drug costs to consumers through a cost breakdown. The categories were aggregated and they're listed here. So first they said production, followed by administration. Number 3 was profit at 22.3%. Then prescription assistance, copay cards, and rebates. The most common explanation reported for drug cost increases on the essential drug report was research and development. And drug samples provided were most often for diabetes at 27% and lung health at 12%. So I wanted to review what was reported over the past 5 years. And that's how long this program has been in existence. 255 drugs, NDCs, unique NDCs, appeared on the essential diabetes drug list with significant increase over 5 years. So since the beginning of the program, we've seen the same manufacturers and drugs repeatedly show up on these lists. So 67 drugs appeared all 5 years. So that means that each year of the program, they had a significant price increase, and 27 drugs appeared 4 out of those 5 years. The average annual price increase for a drug on the essential diabetes drug list with an increase was 7.5%. And the average total price increase from this list over the 5 years was 27.8%. And over the years, the average increase in price per medication has trended down, while the number of medications which experienced a price increase have increased. So I went through that very quickly. That's all that I have for my presentation, but I'm happy to answer questions.
Thank you so much. Members, do we have any questions regarding this presentation?
Yes.
Senator Hardy, please proceed.
Thank you. So simple question, where are we going with this? Are we doing anything with it? Are we wrapping this into the insurance coverage? Are we putting this on the budget for the state to pay? Are we putting a limit of what people can pay or what wholesalers can charge? Where are we going?
So my answer to that is at this point, we're gathering information, and I think we do need to decide what to do with the information. I do have some suggestions. I think we missed a slide as well. I had a manufacturer slide that I don't think we saw, but a lot of the reports regarding essential drugs had no information because they didn't increase in price. So we have this really big group of essential diabetes drugs, and those manufacturers did report, but the answer quite often was there was no increase. And I don't know how much value there is in that report. I think we had 79 reports and only 13 had usable information. So I think a focus more on things that did increase would be of more value, rather than just because you're this kind of drug, you're an essential diabetes drug. And if we wanted to draw more medications in, because like I mentioned, 180 drugs was all we drew in with the over 40. It appears by dropping the percentages, we would draw in more medications rather than dropping the number, dropping the $40. Also a high launch price, like we don't do anything with launch price. We only do what I discussed here, a high launch price. But some states do that. Some states charge fees for participating, not just a fine.
I guess one of the things I'm asking is, we took a snapshot of one area of drugs and their charges versus the whole spectrum of medications and their charges. And to wit, I read in the Wall Street Journal, for instance, that they looked at everything and the drug prices have gone up 1 point something percent in total. So it seems to me a company may have said, okay, we can do something for one group of medicines as opposed to all groups of medicines. So are we comparing the total cost of medicines, or are we, as I see, we're doing a snapshot of one group or two groups? One is diabetes and one is everything that's been increased over $40. What are we going to do with it? Are we going to regulate this in some way? I mean, it's a report, but it may be above your pay grade to say what you are going to do with this.
So, and Senator Hardy, that I might be able to chime in on that. The questions that I would defer to our presenters would probably more entail as to the updates of the work that the transparency program is establishing since funding it from the last session. Any regards to policies on what we use with that data, or any recommendations that come out of that, would be in the purview of this committee, whether it's in our BDR allocations that we receive per NRS, or I guess that's a discussion between all of us as to what we want to do with. I guess the main important thing is to gain transparency so that all stakeholders have the availability of that data and information to make determinations as to what we want to prioritize. So it's not really a question for them, that's more for us. So, and I'm happy to chat offline if that's something that you're interested in, and I'm sure Peters shares that same sentiment. But if there are any other questions that you probably have for the program manager here, I would definitely urge you to, if you have any other questions, I'm happy to entertain that right now.
Thank you, Mr. Vice Chair. I guess my point is you're comparing something and you're leaving out a whole lot of other things because we're only comparing one small group of medicines. Thank you.
Great. Yep. Thank you. Chair Peters, did you have a question?
Yes, thank you. I think you highlight really the point of this activity, which was to start with a baseline of what does the data look like, and then really drive into what do we have access to, what do we need access to, and how do we get to a place where patients are the most protected. At least that's what I see in this data. And it's not unusual when you're assessing data to take a glance at it so that you can kind of suss out trends. And then you take an analytical approach to how to move forward with that data in the future. I had a question though related to your breakdown or the reported breakdown of costs for each medication that was medication that was provided on. This is not your review of data collected slide 12. They were required to specify drug costs to consumers through a cost breakdown. The breakdown included production, administration, profit, prescription assistance, copay cards, and rebates. And then there's a statement here: the most common explanation reported for drug cost increases on the essential drug report was research and development. Well, where does research and development fall within these categories and percent breakdowns of the cost of drugs? Is that in production? Is that in profit? Like, where does that lie?
It is actually a different report. So there's two different places these things are reported, and one is the essential drug report versus the report where there was an increase. So it's two different reports I refer to there.
I'm going to ask that that staff follow up with you and get those reports and distribute those out to us, because I'd like to see those. But I'd also like to know where the drug companies are putting that cost for research and development? Is that a part of the production cost, or is that a part of their profit their profits? Because that changes the interpretation of the data and where those investments are going back into the product.
Okay. Yes, you could do that.
I think that was really the most important question I had to ask today. And we'll have follow-up questions for you, Ms. Fox, on what this data looks like and some of your suggestions for how to move forward in the data analysis. I think that this is important work being done. Transparency in medicine is something that we're trying to tackle all over the place. Any entity in the medical industry will tell you that somebody is not showing us everything. And so what we're doing here is important, but we need to continue moving forward with some kind of goal, as I think the senator was getting at. Thank you, Vice Chair.
Thank you so much, Chair Peters. Any other questions from committee members? I don't seem to see any, so thank you so much for this presentation item. I'm sure we'll have more discussion as to how we can financially sustain this program in the future and what we can do to support it, but I'm sure there's a lot of other things that we can cover. So moving on from this presentation item, let's go to agenda item 11. We're close to the end of this meeting. We have an update on Senate Bill 396, which authorizes public agencies in Nevada to enter into agreements with private entities within or outside of the state for the purchase of pharmaceutical or medical services. We have Dr. Beth Slamowitz, who is a senior policy advisor on pharmacy. So please proceed when you're ready.
Thank you, Vice Chair Vignante. I'm going to go ahead and bring up my presentation. And just give me the thumbs up when you all can see it. That would be great.
Please proceed.
All right. So thank you, Vice Chair Vignante and Chair Peters and members of the committee. My name is Beth Slamowitz. I am the Senior Policy Advisor on Pharmacy for the Department of Health and Human Services. And I'm going to give a brief update on Senate Bill 396 today. Mr. Ashton earlier alluded to Senate Bill 396 and the fact that that particular bill authorized a public agency to enter into an agreement with another public agency or private entity, basically addressing interstate and intrastate agreements for the purchase of prescription drugs, pharmaceutical services, or medical supplies. So as part of the passage of SB 396, the state was able to enter recently into an interstate agreement with the Northwest Consortium. This agreement was announced by Governor Sisolak back in late February. We recently signed the agreement in May, and we are in the process of moving forward to initiate some projects out of that agreement that was signed. So just to give you some brief background, I've presented on the consortium before, but for this committee, some of the members, it might be new information. So the Northwest Prescription Drug Consortium was formed between the states of Oregon and Washington, and it was designed to meet the broad and unique pharmacy program needs of both public and private entities. It operates through an administrator by the name of Moda Health, and then it also has a pharmacy benefit administrator by the name of Navitas that's contracted with it. Different types of items that the consortium operates include a pharmacy benefit administrator, a discount card program. They also operate drug vouchers, workman's comp, and also recently Medicaid prescription drug management. The goal of the member states, Oregon, Washington, and now Nevada, is to secure optimum pricing through pooling and evidence-based prescription drug purchasing. They operate under primary principles, which are for public sector purchasers. They are a completely and fully transparent operation. They utilize pass-through pricing for pharmacies. That means that all discounts and rebates are passed through to the pharmacy counter for consumers. 100% of all manufacturer rebates and fee payments. They work off of a fixed administration fee. And most importantly, it is operated by states for states. So participation from other states increases the value for public purchasers. So it is now a 3-state agreement with hopes that additional states will join in the future. So next I want to present on the dual pharmacy benefit manager solicitation and implementation. Although SB 396 was not necessary for this to take place, I wanted to kind of just give an update in terms of what's been happening within the state in terms of pooling our purchasing power and utilizing that in terms of the payment or purchase of prescription drugs. So this is just a really brief timeline. Back in September of 2019, there was a request for information that was released looking at solicitation for pharmacy benefit managers for the fee-for-service Medicaid population. It was decided when the request for proposal went out in February of 2021 that it was going to be a dual solicitation. It was with the fee-for-service Medicaid as well as with the Ryan White or Nevada Medication Assistant Program. The idea was that both of those programs are payers of last resort. They also utilize rebate revenue for the purchase of prescription drugs. And so it was an ideal partnership to solicit for a single PBM. And so that RFP or request for proposal resulted in Magellan Medicaid winning that proposal. And they just recently went live July 1st. So we're just in the beginning stages, a couple weeks in. So really, there were very specific objectives in combining that solicitation and moving forward to a combined RFP and a combined pharmacy benefit manager for both programs. Mostly it was to obtain comprehensive services for both programs. The State of Nevada Division of Public Behavioral Health hosts the Ryan White HIV and AIDS Part B program. And then the Department of Healthcare Financing and Policy is where the fee-for-service Medicaid program is housed. It was in the hopes to improve each program's ability to manage the pharmacy benefit manager, be able to hold the pharmacy benefit manager vendor accountable for both service and cost commitments. There was also opportunity for flexibility to incorporate technology and tools, innovative business techniques, hopefully in the that it would enhance quality of care under the pharmacy benefit. Some of the items forward thinking with both programs. NMAP has a medical advisory committee, and Medicaid works under the Silver State Scripts Board, which is technically their pharmacy and therapeutics. And then they also have a drug utilization review board that manages their clinical policy. And so being able to combine the programs under one PBM is also giving us the opportunity to leverage some of those advisory boards to make sure that we are presenting the most cost-effective as well as clinically effective and appropriate medications to the population in Nevada. Also, the effort was to reduce administrative burdens on both providers and beneficiaries, control the growth of the pharmacy benefit expenditure. That's been a common conversation on both the federal and state level and nationally, reducing those expenditures to the state as they continue to push healthcare costs forward. Data and analytics is a huge piece of this as well, and being able to review and analyze and report drug usage. There are folks in both programs that both benefit from the medication assistance HIV program as well as with Medicaid. And so being able to have that data in one place and be able to combine the access to that data hopefully will yield positive results. And last, consolidating the PBM contracts and services across the state programs in the hopes of reducing some of the administrative burden, but also reducing the contract cost, which we were able to do significantly. And lastly, I want to add, just because it was brought up under public comment at the beginning of this meeting, as part of this solicitation and implementation, Nevada did join the National Medicaid Pooling Initiative, otherwise known as NMPI. And as stated earlier, it is a multi-state purchasing pool. There are roughly about, I believe, 14 states in it now. But Medicaid does have the Silver State Scripts Board, which still determines placement of the preferred drug list. There is a psychiatrist that is on that board. And so Medicaid is very cognizant of making sure that there are appropriate medications and options, especially in that field of mental health. So I just wanted to make sure that that was included, since that was brought up at the beginning. So that concludes my brief presentation. So I'm available for questions if there are any.
Thank you so much, Dr. Samowitz. Do we have any questions? Not here.
Mr. Vice Chair.
Senator Hardy.
Mr. Vice Chair. Thank you, Mr. Vice Chair. On page 7, fourth bullet point from the bottom, reduce administrative burdens on providers and beneficiaries. I understand the concept that we're doing ultimately to save money and pool and do all of those kinds of things. I suspect the managed care organizations are interested. Does that mean that the managed care organization does not have to include a pharmacy benefit if they're under this program, or are they still on the hook for providing the pharmacy benefit? What is going to be their obligation under this new dual pharmacy benefit manager implementation?
So thank you, Senator Hardy, for the question. So just for clarification, the solicitation that took place and the implementation was for pharmacy benefit management services, strictly for the fee-for-service Medicaid population, as well as the Nevada or the medication assistance program for Ryan White. The managed care organizations are separate. They manage their own pharmacy benefit, each one of them, and they each contract with their own pharmacy benefit manager. So this solicitation did not include managed care. The pharmacy benefit has not been carved out. This was strictly a solicitation for the fee-for-service population and pharmacy benefit.
All right, thank you. That clarifies it. Appreciate it.
Thank you so much, Senator Hardy. Any other questions? I don't think I see any, so we'll go ahead and close this agenda item. Thank you so much, Dr. Slamowitz, for presenting. Okay, we have reached the final presentation item. It is item number 12 on the agenda, which is the final update on the COVID-19 health crisis interim study pursuant to Senate Bill 209. I am the presenter for that item, so I'm going to go over, if it's okay with all the members, I'm going to go over a few of the documents that are online, and I'll walk through some of the background information and the recommendations. And then if there are any other further questions, I'm happy to entertain them or have committee staff address them as well. So again, I am Senator Fabian Danyate, representing Senate District 10. Part of Senate Bill 209, which was passed during the 2021 legislative session, required the Joint Interim HHS Committee to conduct a study on the COVID-19 crises. Chair Peters appointed me to lead SB 209, and during this time, within the last few months, we've been hosting different roundtable discussions with various stakeholders throughout the study and throughout the state. And so I want to start off by mentioning some of the findings that we had from our third roundtable, which was held on May 26th of this year. This roundtable focused more on a conversation that is always left behind with COVID-19, which is a public health workforce. Not to be confused with a healthcare workforce. We always talk about nurses, doctors, but there's also the public health workforce that contributes to the response. And so the stakeholders that were involved received questions in a similar respect on what the public health infrastructure looks like, how we can improve the workforce in general, and to consider the creation of a public health service corps. And on pages 1 and 2 of the handout that you have, you will find a summary of the discussion along with the priority areas that were identified by the stakeholders and policy recommendations. And I want to highlight a few of them for your attention. Priority areas for public health infrastructure are: 1, non-categorical flexible public health funding. This is important for in times of an emergency. Number 2, public health workforce growth and initiatives. And 3, data modernization and technology enhancements. Similarly, stakeholders identified funding as the greatest need to strengthen the public health workforce, followed by providing more incentives for a public health career. This could be done through loan repayment programs, more diversity in the field, and evaluating and building on the workforce pipeline. It was also intriguing to learn that stakeholders recommended support for public health workforce pipeline by investing in outreach in K through 12. For example, youth could be introduced to and engaged in public health careers through the Nevada Department of Education's career and technical education programs throughout the state by adding an emphasis on public health careers. Additional policy recommendations that could be summarized from this stakeholder roundtable were: number 1, funding with a priority to establish dedicated flexible funding for public health; 2, revising Chapter 439 of NRS to enable the establishment of rural health districts among non-adjacent counties; 3, to provide support, including funding for academic health departments and internships, grad assistantships, and fellowships to improve the public health pipeline; and 4, to join certain licensure compacts to eliminate barriers to mobility for certain medical professionals, such as nurses. Many stakeholders also recommended the creation of a public health service corps, and such a service corps could repay the educational loan debt of public health professionals in exchange for their service at the local health department across the state. We have similar programs for physicians, and so there was a conversation about extending that to folks that work in public health. And finally, the last roundtable that we had was held on July 12th of this year. This roundtable engaged conversations on policy recommendations for health equity issues and populations that were disproportionately affected by the COVID-19 crisis. In this particular roundtable, we discussed affected populations such as children attending childcare and K through 12, racial and ethnic minorities, vulnerable populations served by local and state social services, and individuals in the criminal justice system. As part of the discussion that we had, these were some of the priorities that were identified. Number 1, behavioral and mental health challenges. Across all targeted populations, there was an increased behavioral and mental health needs that were identified. It's clear that the COVID-19 pandemic exacerbated many of the mental health challenges that we had with our children and youth, particularly Native American communities and those individuals served in the criminal and juvenile justice systems. And based on this roundtable, according to stakeholders, the demand for behavioral and mental health services far outpaces the supply for services in this field, which increases health inequities. With regards to young children, stakeholders discussed that young children in the school system were also disproportionately impacted by the pandemic. For instance, limited early intervention services during the first 2 years of the pandemic led to spikes in behavioral and social issues in schools in the primary grades that could not be adequately addressed due to shortcomings in the current system. Number 3, health disparities. Stakeholders reported that across Nevada, communities with racial and ethnic minorities had higher rates of health conditions and chronic diseases. The COVID-19 pandemic exacerbated these health disparities. For example, access to vaccines was more difficult for these communities, and the rate of severe illness and death from COVID-19 was disproportionately higher compared to other counterparts. And an interesting conversation that also came up was with regards to food security. We had folks from the different food banks present, and they mentioned that they had a 40% increase in need during the beginning of the pandemic, and moreover, a significantly increased demand arose for food delivery services for the frail, elderly, and for the disabled population. They mentioned that they're still experiencing some challenges now due to inflation, which of course could be contributed to the COVID-19 pandemic. And then the last one, the most important thing that came from all this is the conversation on workforce. I think in general, yes, we recognize the need for a public health workforce, but the COVID-19 pandemic led to shortages across the whole entire system, whether it was in criminal justice, education, social services sectors. For instance, stakeholders reported vacancy rates ranging from 18 to 40% due to burnout, lack of competitive salaries, and increased workload. And the recruitment of new staff is also a challenge. For example, a training academy for new correctional officers had to be canceled because of the lack of applicants. And I think it's clear that the community also faces severe shortages of personal care service providers and child care providers. And then in terms of policy recommendations that were delivered from this roundtable, stakeholders recommended to invest in the primary prevention of chronic diseases to improve healthcare outcomes. Some stakeholders recognize the need to address information gaps and misinformation amongst non-English speakers, which would require us to invest in health literacy efforts. And then the last and final thing is that the state should focus on emergency preparedness. The example used by stakeholders was an increase in planning for crises in food security and food delivery, but this could be applied to many other sectors, including improved access for vaccines for populations facing health disparities, childcare options for frontline workers, or crises planning for crucial economic supportive services such as SNAP, food stamps, and unemployment benefits. So that concludes the report for the third and final roundtable discussion. The committee staff are in the process of preparing a final report that's going to detail all of this more comprehensively, and eventually it'll lead to BDR recommendations that we could either choose as a committee to introduce ourselves, or if there are any members that would like to introduce them themselves as part of their allocation, that's also an option. I'm happy to answer any questions that any of the committee members might have from these two roundtable discussions, and if there's anything that you'd like to be seen in the final report. Assemblywoman Titus.
Well, thank you for that, and that's a lot of effort and time and thought that have gone into it. So thank you very much for everybody's effort and all those roundtable discussions. Moving forward, as Senator Doc Hardy had brought up earlier about, well, what do we do with this information now? And certainly, I have mentioned a couple times, and I understand we're going to look at it on a work session maybe next time around about in some of my rural counties that I'm going to represent have reached out about enabling them to have a health district that are not contiguous or touching or contact. So certainly we can actually move forward and suggest, at least for that one, that becomes a BDR, because that's something we can do moving forward and actually glean something positive with all that work that you've done. And I think that's really, we have so many studies and we have roundtables and we have discussions and presentations, but what do we actually accomplish other than identifying problems? But then we have to identify solutions. And so being able to narrow it down to some concrete solutions where individuals have come up with, like those counties who want to do that. And I think that's real positive when we have people coming to us with, hey, here's our solution, here's what we'd like to do. So thank you for that, and looking forward to having that particular BDR go forward from this committee, because I think that a committee bill has more weight and more chance as a bipartisan effort to go forward in the next session.
Yeah, thank you so much, Assemblywoman Titus. I would agree. Yeah, I think that there were conversations that came up during our discussions that we do have to take some review as to how we prepare in terms of emergency preparedness and how we help counties and local jurisdictions prepare for future crises, whether it's a pandemic or a wildfire or anything. So I think that was one of the positives that we had, and you are right. It does allow for the opportunity for collaboration. So hopefully we can, I think Chair Peters and I will work together, and we'll be bringing it to you with some sort of recommendation for the next work session. If there are do we have any other questions for anyone maybe in Las Vegas? Doesn't seem like Chair Peters.
Vice Chair, I just want to extend my gratitude to you and staff for completing this task. It was quite a heavy lift, including a lot of stakeholders from a variety of areas. And you've done a wonderful job. I've heard great things, feedback from the folks who have met with you. And I think that Dr. Titus nailed it. Our goal is to come up with solutions in this committee. That's what we've asked every person who's presented in this committee to do. Is you have a problem, come in with a solution. The suggestion may not be what sticks at the end of the day, but at least we have a starting point to start building with our brain power and other stakeholders on what it is that will work for the state of Nevada to address these issues. What are our priority issues? Where do we see similarities in different organizations and agencies? And how can we leverage those dollars as well as those policies and practices. So I'm really looking forward to the final report and to sussing out over the next month with you all what it is that we will be bringing as our BDR allocation for this next legislative session.
Thank you so much, Chair Peters. Any other comments or questions? Seeing none, I'll go ahead and close this agenda item. And we will go ahead and we've reached the conclusion of this meeting. So now we are at our last item, which is public comment. We'll start with public comment from those in the physical locations. Doesn't seem we have anyone here in Carson City. We'll go to Las Vegas and then we can go virtually. So is there anyone in Las Vegas that would like to? I don't think we have any.
No one in Las Vegas.
Thank you so much. BPS, is there anyone virtually that would like to provide public comment at this time?
Thank you, Vice Chair. To give public comment, please press raise hand in your Zoom window or *9 on your phone to take your place in the queue. Caller, you are unmuted and you may begin.
Good afternoon, Vice Chair Tanate and members of the committee. For the record, this is Christine Thompson, board member of Nevada Tobacco Prevention Coalition. Nevada Tobacco Prevention Coalition's policy chair, Tom McCoy, submitted written comments and other supporting documents to the committee yesterday, and we thank you for this opportunity to provide comment today. The Nevada Tobacco Prevention Coalition is comprised of collaborating public health, healthcare, and private partner organizations. Our mission is to improve the health of all Nevadans by reducing the burden of tobacco use and nicotine addiction. NTPC strongly encourages members of the committee to consider the following policy recommendations to equitably protect the health of all Nevadans. First, increase tobacco prevention and control funding to $6.2 million annually. That would be $2 per person in Nevada, while sustaining the $5 million fiscal 2022-2023 biennium investment in youth vaping prevention, and allocate funding to local communities to implement tobacco control prevention and cessation promotion programs. Additionally, protect and strengthen the Nevada Clean Indoor Air Act to close the loopholes so that every employee of indoor workplaces and public spaces is protected, and include minimum distance requirements from entry and exit spaces. Establish comprehensive smoke-free laws to save lives and reduce Nevada's health spending by an estimated $500 million annually. Restrict flavoring additives by prohibiting the sale of all flavored tobacco products, including menthol, therefore promoting additional health equity. And limit youth access to flavored tobacco products through tobacco retailers. Addressing youth access via tobacco retailers we recommend, should include increased enforcement and accountability for tobacco retailers, and to support community-based education, including ID checking and other means. We thank the committee for your work and for your consideration of this information and the documents presented. Thank you.
Good afternoon. This is Maya Holmes. I'm the Healthcare Research Manager for the Culinary Health Fund. And I want to thank the chair, the vice chair, and the committee for discussing the affordability of prescription drugs today. On agenda item 9, we were very active in the Interim Health Committee study concerning the cost of prescription drugs and supported some, but not all, of the committee's recommendations for the 2021 session. We appreciate that the committee's work is being revisited. We also want to thank DHHS for the tremendous work they are doing implementing the Drug Purchasing Coalition and the Drug Price Transparency Reporting. The transparency legislation was critical to start shining a light into the black box of drug prices and their unrelenting price increases, so the public can really just start tracking what is happening in the market and also move towards developing well-informed policy based on real data. It is absolutely critical for Nevadans to have access to the prescription medications they need at an affordable price. But I do want to underscore for the committee that any proposals that do not address the fundamental problem of high-cost prescription drugs is simply a whack-a-mole approach that shifts costs around. Patients, employers, the government, taxpayers, and other payers will still pay those costs in the form of higher premiums, deductibles, copays, and co-insurance. In the U.S., we pay the highest prices in the world for pharmaceuticals, helping to make the pharmaceutical industry one of the most profitable industries on the planet. It spends incredible sums on political lobbying to protect their business model and profits and prevent meaningful reform to address their out of control and unaffordable prices. Manufacturer prescription drug prices are egregious and out of control. Just this past Tuesday, the non-pharma funded patient advocacy group, Patients for Affordable Drugs, released a report that the median price for a new prescription drug is now $180,000 for a year's supply. That is up from $2,000 in 2008. It's just mind-blowing. Drug companies and pharma-funded patient groups rely on proposals that sound good on the surface but do not actually address the root problem, which is the prices that the manufacturers set. They want to propose price caps on copays, eliminations of deductibles, allowing manufacturers to use coupons for high-cost brand drugs over low-cost generics, and rebate sharing at the pharmacy counter. While patients absolutely do need relief, these proposals ignore that fundamental price problem, which is that it's the manufacturers who are setting the prices and how that contributes to overall healthcare costs. As a nonprofit self-funded health plan, we cover approximately 130,000 lives in Southern Nevada. Our goal is to ensure a healthcare market that provides universal access to quality, affordable healthcare, including prescription drugs. Like all Nevadans, our participants are struggling with inflation, housing, gas, food, and other costs. On healthcare, they, like all Nevadans, need solutions that meaningfully reduce, not exacerbate, our healthcare costs and expending. We cannot support Band-Aid legislation that fails to address the root of the problem and allows pharma to continue to price gouge and drive up premiums and out-of-pocket costs for everyone. Again, we're really very appreciative that the committee is discussing these issues, and we look forward to participating in those discussions going forward. Thank you.
Vice Chair, there are no more callers for public comment at this time.
Thank you so much. Sure, Assemblywoman Titus?
Thank you, Co-Chair and Chair. And I would just like to offer, before we close, if there's no other phone or public comments, that if I might just suggest that moving forward, I had already mentioned that we, as one of our BDRs, look at the health districts not having to be counties that are touching, but also I would suggest that perhaps you had a suggestion about funding. We already have a source of funding to reimburse rural providers, the PAs that have come like to my clinic, and myself, I was paid, supported through med school by my county. But we may be able to put a bill in, because again, I'm about solutions, put a bill in that just adds the words public health professionals in the already existing statute that reimburses under that for physical therapists, PAs, and that may be one of our bills that we use just to add that profession underneath that litany of people, because we have social workers, et cetera. So maybe our staff can look into that if it would be, what would that be a simple fix? That's something we may actually be able to do. And then the third thing was the nursing compact. I think it would go well for this committee to look at that as one of our bills, but not just for the nursing compact. I think it was mentioned by Dr. Packham that there was, we've only signed 2 out of 8 of the possible compacts that could be done, and maybe we can search that a little bit more about using that as one of our bill drafts. Thank you.
Thank you so much, Assemblywoman Titus. I think that's something that we can probably all discuss before we prepare for the next work session, and I think Chair Peters probably and I will work together to address some of them. So hopefully we can fix some of those changes. Yep. Great. Okay. Now that we have, are there any other comments from any other committee members at this time? Seeing that we don't have any more public comment or any more comments from the committee staff or the committee members, I just want to thank the staff for helping us out today. It was a pleasure joining you all in Carson City. And just as a reminder, our final meeting will be held on August 18th, 2022 at 9 a.m. and we will have a work session on that day. So thank you so much, and the meeting's adjourned.